hear me all right in the back? Everyone can hear me? Awesome. So I'm going to start, and if people trickle in, they're not going to miss much because the beginning will really be more normal anatomy and histology. Do not be overwhelmed. We'll only do half of these sections. Dr. Eagle insisted that we split it into 2-hour-long lectures, so you're going to learn more about the eyelid pathology than you will ever want to know. So let's take a look and do a very brief run through the normal anatomy. Now, as you would expect to see clinically, upper eyelid is longer. It has longer tarsal plate. It has deeper fornix when you compare it to the lower eyelid. So if you cut the eyeball and grossly look at it, you can appreciate the same features. Upper lid has longer tarsal plate, overall looks rectangular in shape, deeper fornix when you compare it to the lower eyelid. And if you look again on higher magnification at the eyelid grossly, you begin to see now the epidermis, or the skin with underlying dermis. And what's unusual about the palpebral location is that the skin rests directly on muscle. You almost never see it anywhere in the body. So this is very important for eye pathologists and surgeons. So if you see actually orbital fat in the biopsy, that suggests involvement of the orbital tissues. And as you know, orbicularis sends projection towards the eyelid margin that appears to us as a gray line, and that's muscle of Riemann. And then more posteriorly, you have meibomian glands, which look lobulated, yellowish within the tarsal plate, and then conjunctiva, the mucous membrane. So again, microscopically, you're going to see exactly the same structures. You're going to see the epidermis with dermis directly overlying the skeletal muscle, or orbicularis, and more posterior tarsus with meibomian glands and conjunctiva. So as you guys know, within the lid margin, you're going to see microscopically exactly the same landmarks that you will see clinically. So you will see the eyelash line or cilia, more posteriorly gray line or muscle of Riemann, more posteriorly openings of meibomian glands within the tarsus, and more posteriorly conjunctiva. So the skin with orbicularis comprise the anterior lamella of the eyelid, and the tarsus with conjunctiva comprise the posterior lamella of the eyelid. So you can see how orbicularis with muscle of Riemann and the gray line really form the plane for dissection that separates the anterior lamella from the posterior lamella of the eyelid. And in contrast, the mucocutaneous junction actually overlies directly the openings of meibomian glands. And you can recognize meibomian glands by lobular arrangement with peripheral layer of germinative cells that look blue, and then they mature to these sebocytes that have central nuclei and abundant vacuolated cytoplasm. So at the mucocutaneous junction, you have transitioned from non-keratinizing epithelium of conjunctiva, which is a mucous membrane, to the keratinizing epithelium or epidermis. And whenever there is any kind of malposition of the eyelid, such as ectropin, entropin, you're going to see posterior displacement of mucocutaneous junction. So basically, you have reactive keratinization, and you can appreciate that both clinically and also histopathologically. So let's take a closer look at the various normal regions within the eyelid skin. And epidermis looks like epidermis anywhere else. It has the basal cell layer where cells look bluish because of higher nuclear to cytoplasm ratio. That's where you will find normally mitotic figures. Anywhere else superficially is abnormal. Then more superficially, you have the squamous cell layer where the cells are polygonal. They have abundant pink cytoplasm. They have intracellular bridges that make them look like prickles. And then finally, keratohyalin granule marks presence of granular cell layer, and then you will have acellular lamellated keratin. So the reason why I'm going through all of these normal features is because you are going to be seeing neoplasms that differentiate towards a certain cell type. And recognition of what's normal will help you then with appreciation and recognition of actual pathology. So I did mention that the eyelid epidermis looks just like skin anywhere else, but it does have important differences. It's very delicate. And that's why, unfortunately, we show signs of aging in the eyelids earlier than anywhere else. It has very delicate surface keratin, unlike any other region. The rete ridges, these projections of the epidermis into dermis, are not as well pronounced in this region as compared to other sites. We don't have well-developed reticular layer in the dermis, but we do have hair appendages with associated glands, which are also somewhat unusual in the eyelid because of the eyelashes and the glands that those are associated with. So here we have the cilium, or the eyelash, and you can see that there are these pale glands which are going into the hair follicle. These are glands of Zeiss, analogous to the meibomian glands. These are sebaceous glands associated with the cilia. And you can also see sweat glands that are associated with the hair follicle, and these are apocrine glands of mole. So if you actually focus on that infundibular region of the hair, you can see the glands of Zeiss with the typical sebaceous architecture. And if you focus deeper in the dermis right there, you see the characteristic bilayered architecture of the sweat glands. And this is the typical apocrine secretion, where the inner layer looks cuboidal, with these projections into the lumen that are called apical snouts, and decapitation secretion, and the outer layer is flattened myoepithelial layer. You also have sweat glands that do not associate with the hair follicles, and those are eccrine glands. So eccrine glands are really found anywhere in the body, but apocrine glands are only found in certain sites, like cilia or eyelashes, ceruminous glands in the ear, hair in the axilla and groin, and that's pretty much it. So eyelid is a very unusual location. We also have accessory lacrimal glands in the eyelids. And this is the typical arrangement, kind of labials with acinine ductules. So for those of you who have rotated through the eye pathology, you know there are many accessory lacrimal glands, right? At least 3 that I know of. Which ones are these? And I will tell you that's not caruncle, because that would be, that's a potential region that can look like that. So non-caruncular region, this is eyelid. Where are we? So there is a clue. Close. So remember, crow's are in the fornix, and these are right next to meibomian glands, right? So at the edge of the tarsus. So these are glands of... That's right. All right. So this is higher mag. So you see acini with basally distributed nuclei, zymogen granules, and ductules, and of course plasma cells that, as you guys know, produce IgA secreted in the tears. So any questions on normal? All right. So let's move on to congenital and to, I guess, appreciation of pathologists, and probably for you guys, we really don't have a lot of pathology on congenital anomalies because nobody submits it. So it's really mostly for your clinical diagnosis. So it just gives us an opportunity to go over through some of the congenital lid malformations. So do you guys know what this is? Exactly. Good job. So you see the characteristic triad, right? Telecanthus, epicanthus inversus, and ptosis. Good. How about this one, if it's congenital? Yep, distichiasis, second row of eyelashes from meibomian glands. This one? And these are more typical sporadic, right, in the upper lid. Yeah, ankyloblepharon. And the last one, which actually sometimes we do see pathology on when they don't discard it. Exactly. So epiblepharon, where there is a fold of orbicularis that rotates the lid margin towards the globe. So this is pretty much one of the few conditions that we do have pathology on, and that's cryptophthalmus. And there are several varieties that are recognized. So complete one, where you basically don't have normal developments of the lids, and you have just strip of skin that goes from the forehead to the cheek without interruption. Okay? Incomplete is what you see in the left eye, where you have incomplete development of upper and lower lids medially. And then you also have some blepharon variety where you have linear dimple joining the lids. And as you know, that's associated with Fraser syndrome, a autosomal recessive condition that has various facial dysmorphic features, polydactyly, syndactyly, urogenital anomalies. So to appreciate what happens pathologically in the syndrome, you really need to appreciate normal development of the lids. Okay, so that's what happens during 4th to 5th month of gestation. As you know, the eyelids folds form, and then they kind of come and fuse together, right? And then they slowly separate around 5th month. And here you can see nearly complete development of the lids with tarsal plate, orbicularis, skin, and you can see early budding of the follicles of the cilia and meibomian glands. And once meibomian glands produce sebum, and once hair follicle produces sebum and keratin, and there is complete keratinization, the lids separate. Okay? Also note the normal underlying embryologically formed structures of the anterior segment, cornea and lens. So that's what happens now in cryptophthalmos. There is no development of the eyelid tissue. You basically see skin. And also note that the underlying anterior segment is severely malformed. And that's why if you think you're going to reconstruct the lids without addressing the underlying issues, you're going to run into the problems. And there have been several amazing studies showing reconstruction of anterior segment in these patients, which was quite successful according to them. Now, this one, you guys, I'm sure all know about because we mentioned it in our pathology. This is phacomatous choristoma or Zimmerman's tumor. And this one you can pretty much clinically diagnose if you know about it. Congenital, inferior medial lid, incredibly firm. So you may think, could this be dacryocystocyst or something, you know? But the firmness is a huge tip-off. And what you really see here is cataractous lens tissue, where it should not be. So the hypothesis is that the surface ectoderm, which is going to form the lens, may potentially get derailed and get implanted abnormally in the tissue of the lid, giving rise to this choristomatous tumor. So what you actually see here is lens epithelium, cuboidal in nature, and these swollen cells that look very similar to the bladder cells of Weddell in the posterior subcapsular cataract, in a background of fibrosis or fibrous metaplasia of lens epithelium. So a very characteristic lesion, both clinically and pathologically. So before we move to the exciting topic of the cysts, any questions on congenital anomalies? No? Okay. So the cysts, actually, that is something you're all going to see, and I'm sure some of you have seen all of them. So in my mind, it's actually more appropriate to talk about what is relevant to you guys rather than esoteric lesions, right? So we will spend some time on these. So do you guys, just based on clinical appearance, can you give me the likely diagnosis here? So it looks yellowish, and I will tell you that if you transilluminate it with a pen light, there is kind of grayish solid material in the lumen that deposits kind of by gravity inferiorly. So what would your likely diagnosis be? Exactly, it's epidermal inclusion cyst. And the yellowish hue has led in the past to incorrect terminology, sebaceous cyst. There is nothing sebaceous about it. So this is the epidermal inclusion cyst. And what you're seeing here is really what looks like completely mature epidermis, identical to the surface epidermis. So when we see the cysts, we always ask ourselves what is lining the cyst and what is filling the cyst, and then we can make a diagnosis. So here you can see, again, the cyst, in this particular case, communicating with the surface epidermis, and clinically sometimes you will see a keratin plug in these, like a little pore. So that's correlate of that observation clinically. And on higher magnification, can you see how the lining is identical to the surface epidermis with mature keratin, with granular cell layer, and with lamellated surface, lamellated luminal keratin that looks just like surface keratin. So if we see many dermal appendages within the lining, we may potentially consider dermoid cyst. Without dermal appendages, epidermal inclusion cyst or infundibular cyst, because some of these arise from dilation of hair follicle infundibulum. Benign lesion, no need to do anything for it, but can recur if you leave a little focus of epidermis in the stroma. Okay, this one also many of you have seen. What are your thoughts? So lateral canthus, bluish hue, transmits light readily. Yeah, so this is hydrocystoma, and the bluish hue to you guys would suggest which one type, eccrine or apocrine? Participate, even the senior residents, because the junior residents may not know. So apocrine, right? So apocrine secretion looks bluish. So that's kind of a huge tip-off, as well as lateral and medial canthal location association with the cilia that you guys can see here. That's what we're seeing. Something that looks like normal apocrine gland, but you have a cystic dilatation, and you can see association with potentially a hair follicle. And this is higher mag, where you see frequently multiloculation with apocrine secretion, very nicely defined here. And here's, as a comparison, eccrine hydrocystoma, where you have more typical eccrine bilayer, reminiscent of normal eccrine sweat gland. So any questions on cysts? Okay. So then we will go into the epidermal-based tumors, and clinically also it's very important concept to remember. So when you evaluate skin lesions, you want to ask yourself, what's the location? So lesions that are located deeply in the stroma, such as cysts, for example, are going to undermine the epidermis without really significant effacement of the normal surface markings. And that's how you are going to say, okay, this is primarily stromal-based tumor, and you will have a certain differential diagnosis. In contrast, the epidermal-based lesions are going to distort normal adjacent surface markings, and you will then be able to give a differential diagnosis, okay? And just like anything, these are subdivided into benign, premalignant, and malignant. So in pathology, we use very extensive terminology to characterize the epidermal changes, which most people hate because there are so many words, but you know, if you get used to them, they can be helpful. So let's go through those words so that when I describe lesions to you, you are familiar with terminology. So compare, this is normal, okay, as a reference for you. So here you can appreciate there is thickening within the epidermis, which looks pink because it looks like the thickening is within the squamous cell layer, mostly, and that's called acanthosis, okay? You can also appreciate more keratin than normal, so that's called hyperkeratosis or orthokeratosis. Here you see separation between individual squamous cells, which is called acantholysis or spongiosis. Here you can see retention of nuclei within the keratin, that's called parakeratosis. And you can also in this lesion see increase in granular cell layer, that's called hypergranulosis. And then finally, can you appreciate how compared to normal, the epidermal cells here are haphazardly arranged and have higher nucleus to cytoplasm ratio and focally prominent nucleoli? So that's dysplasia. And associated with this dysplasia, you can also see hyperkeratosis and parakeratosis, yes? So all of these are the terms that we will now use. So let's talk about benign lesions first. And really, benign lesions, for us, they're like papillomas. That's what we care about. We care about papillomas. So that's a very common papilloma here. What are we looking at? Yeah, seborrheic keratosis. So flat, sessile, greasy. That's what you see histologically. Very nice histologic correlate. Sessile papilloma, meaning broad-based. The fronts, or these leaflets of the epidermis, look flat or squared. The overall look frequently looks blue because it's considered to be a neoplasm with adnexal differentiation. And you see characteristically the pseudohorn cysts and basket weave pattern of hyperkeratosis. Okay? So the papilloma is a nonspecific term. You look at all of these features to give a precise characterization and terminology. So this is a nice example of seborrheic keratosis. Sometimes it becomes irritated or inflamed, and it can look as if it's growing in, and it can be associated with significant inflammation. So an example of this is called inverted follicular keratosis. And we can see acantholysis, which is a characteristic feature of this lesion, associated inflammatory infiltrate, and formation of these balls of squamous cells, which are called squamous eddies. So that's inverted follicular keratosis or inflamed seborrheic keratosis, which, because it's a reactive lesion, or I should say it's a lesion with reactive change, can grow rapidly and clinically can be worrisome. So that's important to keep it in mind. Okay, what are we looking at here in the lid? So looks like pointy. Yeah, so that's verruca vulgaris, right, or a wart. So again, you see histology that exactly correlates with your clinical observations. Again, a sessile papilloma with pointy or spire-like or digitated fronts. It looks pink here because there is acanthosis. On the apices, there is parakeratin because of rapid turnover. This is a rapidly maturing lesion. And we also see hypergranulosis at the base, which is a hallmark of viral-induced lesion. And you know this is frequently induced by HPV infection. And sometimes you may even see something that you will see in cervical samples. You will see koilocytes, which are HPV-infected cells. And if we do immunostains or any other genetic testing for HPV, you will see evidence of HPV infection. So this is an immunohistochemical stain, which is a nuclear stain that shows that koilocytes have brown byproduct of the antigen-antibody binding that tells you that the nucleus contains HPV virus. So HPV-infected skin lesions typically do not give rise to squamous cell carcinomas like we expect cervical, mucosal, conjunctival lesions would. Very rarely, HPV in the skin in wart leads to development of carcinoma. And again, that is typically seen in a context of immunosuppression. So cutaneous warts are generally benign lesion, and you do not have to be concerned about progression to cancer. Okay, so let's now move on to this one, which is a fibroepithelial polyp, and we can call it acrocordon or a skin tag. Eye pathologists will call it squamous papilloma. And typically in dermatopathology, that term is reserved for large lesions. Small lesions, fibroepithelial polyp is applicable. So that's what it looks like. It's now pedunculated. It's no longer sessile. It has a narrow stalk, and it has a rounded fronts with fibrovascular cores. So let's look at them side by side. Can you recognize each of them? Pedunculated, rounded fronts, right? Spire-like fronts with hyperkeratosis and parakeratosis, and sessile with flat-topped fronts. Okay. So you all know that actinic keratosis can progress in some percentage of patients to squamous cell carcinoma, and you can, I'm sure, all recognize clinical features of this lesion. Can present as patch with erythematous base and hyperkeratosis. Sometimes it can present as a cutaneous horn. And it's typically squamous lesions that have erythematous base to them, so that helps distinguish them from basal cell cancers. So this is what we're going to see. Compare this region with pathology to normal. So that's going to be your reference point. So that's normal. You see acanthosis. You see hyperkeratosis with parakeratosis, inflammation, and dysplasia. Again, this is the edge of that lesion. Acanthosis, parakeratosis, dysplasia, and note loss of granular cell layer, which again reflects rapid turnover. So when we have rapidly cycling cells, epidermis does not mature through regular progression into granular cell layer and acellular keratin. You have, as a result, parakeratin. Doesn't mean it's malignant, right? Because verruca vulgaris has parakeratin. But in this case, it is a marker for dysplasia. And of course, actinic keratosis here is a huge tip-off. It tells you it's sun damage-induced lesion. So let's move on to frankly malignant lesions. So when you have squamous cell carcinoma, the lesion now invades the stroma, right? And squamous cell carcinomas, I should rather say invasive squamous cell carcinoma will invade the stroma, in situ cancers will not. And squamous cell carcinomas of the lid account for up to 10% of all primary eyelid tumors. They are typically seen in the elderly, in people with fair skin, with sun exposure and immunocompromise, and sometimes in inherited cancer syndromes. So this is the classic look. Again, the lesion looks pinkish. It's ulcerated. It's hyperkeratotic. Or, in this case, looks like cutaneous horn with a base that's very suspicious for tumefaction, right? Here's an example of cutaneous horn-like presentation on the lower lid, which is a typical location for squamous cell carcinoma because sun exposure is strongest on the lower lid. So most squamous cell cancers are expected to occur in the lower and medial lid, just like basal cell carcinoma. So, as I mentioned, actinic keratosis is a precursor of this lesion, and you can now, I'm sure, go through all of the defining features of actinic keratosis. Here's an example of actinic keratosis that progressed to squamous cell carcinoma in situ. So can you guys appreciate here full thickness replacement by dysplastic cells? Can you also appreciate focal invasion into the stroma? So this is an example of microinvasive squamous cell carcinoma that arose in actinic keratosis. Here's an example of de novo squamous cell carcinoma in association with squamous cell carcinoma in situ with an overlying ulceration. And squamous cell cancers look pink, right? So they look pink, and when they're invasive, they're below basement membrane. They look pink because in their majority, they retain squamous differentiation, which is characterized by cytokeratin that looks pink, intracellular bridges, and keratinization. And here you actually have keratinization with an individual cell that's called dyskeratosis. And aggregates of dyskeratosis are called keratin pearls. So you can see here how the cells look frankly atypical, but they still have polygonal shape like normal squamous cells, and they have intracellular bridges like normal squamous cells. And they produce keratin like normal squamous cells, and that gives us the clue that this is squamous cell carcinoma. So just like anywhere else, prognostic features of this are size, extent of invasion, perineural invasion. Here we can see squamous cell cancer that's wrapping around the nerve. And that's how eyelid squamous cell cancers can locally recur, invade really, really deep into the orbit, and potentially into the brain. So local recurrence with deep invasion can be a feature of these. Differentiation is important. This is an example where you almost do not see squamous differentiation, right? So poorly differentiated tumors tend to behave more aggressively. And it can occasionally metastasize to regional lymph nodes most commonly, rarely distantly. So again, differentiation and size are important prognostic markers for regional metastasis and distal metastasis. This is an example of a patient with markedly enlarged parotid gland, probably because of metastatic carcinoma in cervical chain. Now, what do you think is the underlying predisposition syndrome in this patient? So you can see that's a kind of diffuse involvement by many, either actinic keratosis or squamous or basal or something. So what'd you say? Could be radiation. What else? What genetic syndrome can predispose to multiple skin cancers? So maybe medical school is closer to basic science? Yeah, say it out loud. Yeah, xeroderma pigmentosum. So this is a patient with xeroderma pigmentosum. Okay. How many of you have heard about keratoacanthoma? Okay. How many of you know what keratoacanthoma is? So it's a very much disputed entity, and it continues to be somewhat disputed entity. In the past, it was thought to be a reactive phenomenon because it grows rapidly and spontaneously involutes. Then it was considered to be a cancer, kind of a self-limited neoplasia, and now I think there is enough evidence to suggest that it is a self-limited neoplasia that recapitulates hair follicle cycle. So hair follicles grow and then they involute. Okay, but it's a tumor that can be seen on sun-exposed skin. It can be seen on the lid, and we need to be aware about it so that we know how to manage it, okay? So keratoacanthoma, as I mentioned, tends to grow rapidly, and it has this characteristic appearance in its full-blown form. It has well-defined sharp edges, kind of rolling edges, with keratin-filled crater, okay? And it can spontaneously involute, but some studies have shown that local metastasis can happen from keratoacanthomas. And there is a thought that this is a neoplastic process that is best regarded as a less aggressive variant of squamous cell carcinoma and therefore should be excised completely. There are several reasons for this to be excised completely. One is that the diagnosis really rests on complete shape of the lesion. Two, if you let it involute in the eyelid skin, sometimes you may have traumatic disfigurement. And three, in many cases, eyelid located, in many cases of the eyelid keratoacanthoma, excision actually showed bona fide squamous cell carcinoma. So we can be wrong clinically, and we do not want to watch and wait in this case, okay? So histology here, cup-shaped lesion, keratin-filled crater. Note the characteristic pushing margin. The lesion does not infiltrate. If you see infiltration, it is not keratoacanthoma, it's squamous cell carcinoma. Here's the base of the lesion. If you just look at this in isolation, I'm sure all of you would be highly concerned about squamous cell cancer, yes? Incisional biopsy in this case is going to give us misleading information. We need entire lesion. Okay. So moving on to a very common cancer for us in the eyelid and anywhere in the skin, basal cell carcinoma. Just like anywhere in the skin, it's the most common primary skin malignancy. And again, we have very similar risk factors that are associated with this tumor as squamous cell carcinoma. So just like squamous cell carcinoma, we will see it more commonly in a sun-exposed location of the inferior and medial eyelids. And it can look pearly with telangiectasia. So unlike squamous cell cancer that looks pink, basal cell looks pearlish whitish, so that's the clinical tip-off. It can have sometimes central ulceration. So these two features are compatible with nodular ulcerative variant of basal cell carcinoma. And sometimes, though, you can have infiltrative tumors that can present as patch-like lesions without clear borders. And those are the ones which are most worrisome because you cannot see the edge of it. So surgically, you may not completely excise the tumor without taking precautions, like frozen section control of margins or Mohs surgery. So basal cell carcinoma, just like squamous cell carcinoma, recapitulates its presumed cell of origin, right? Basal cell carcinomas presumably arise from the stem cells in the hair follicle infundibulum. So you can see how this tumor closely resembles the normal hair follicle infundibulum. And in fact, you almost never see basal cell carcinomas outside of hair-bearing skin. No basal cells on palms and soles, no basal cells on mucous membranes, usually, right? So this is a tumor of hair-bearing skin. And with its reminiscence with it being reminiscent of the hair follicle infundibulum, you can see how the tumor looks blue, has polygonal architecture, has characteristic peripheral palisading where the cells arrange perpendicularly to the surrounding stroma, and has characteristic retraction artifact of the nest of the tumor from fibrotic and desmoplastic stroma. So these are typical features of basal cell carcinoma with nodular growth pattern. Note that the nuclei of these cells are relatively bland. You don't really see significant pleomorphism. You don't see a lot of mitosis. You don't see prominent nucleoli. That is very important when you try to distinguish blue tumors from each other. So this is the look of basal cell carcinoma as compared to what you're going to see in sebaceous carcinoma, for example, or melanoma, okay? So nodular basal cell carcinomas, and you guys are all familiar with its management, can be excised relatively easily with surgical or frozen section control of margins. Okay, so that's an example of characteristic pentagonal resection. This one is much more problematic, right? So this patient presented with this characteristic rodent ulcer. All of you would be thinking here of basal cell carcinoma, right? And in this setting, usually patients have extensive social history that precludes them from getting timely care. So they actually did, on this patient, multiple biopsies to confirm that this was indeed basal cell extending everywhere. And as you can see, all biopsies came back positive for basal cell. They also did imaging, which showed deep involvement of the orbit with potential focus of bony involvement, okay? So based on all of that, they decided to proceed to exenteration, okay? So they exenterated this orbit, and the final pathology was morpheoform or sclerosing basal cell carcinoma, as you may expect, where the tumor infiltrates the stroma without tumefaction. So you don't really see appreciable nodularity. It just grows into the stroma with these basaloid bands and strands of cells associated with significant desmoplasia. Yes?
What makes it a rodent bitten?
So it's the ulceration. I don't know why it's called rodent. It's like somebody is nibbling. So,
Around the
so it's not. So the name is not synonymous with eyelid location. It's more the shape. So it's this characteristic kind of nibbled edge without tumefaction, which suggests to you an infiltrative cancer. So exenteration, right? And then you end up having this specimen where tumor is in the bone. So they could not obtain clean margin. And that raises to us the very important topic of how basal cell carcinoma in periocular region can kill you, right? It typically does not metastasize. Rarely, but almost never. It just grows, and it can grow into the sinuses and the brain, into the vital structures. And it can cause death by direct extension. And in ocular region, when we want to spare the function or the eyeball, or when we are limited in our location, we can't go into the brain, right? That presents a real problem, okay? And that is why for these types of cancers with infiltrative morphology, like sclerosing basal cell carcinoma, or basosquamous carcinoma that can behave like squamous cell cancer and also infiltrate deeply, or metatypical basal cell carcinoma that also kind of is in between basal and squamous that can infiltrate really deeply. We have a problem, and the answer is targeted therapies, right? Radiotherapy works, but also targeted therapies are now on the market that can help us. And our understanding of the underlying molecular pathway for basal cell carcinoma has really opened the door for these targeted therapies. And basal cell carcinoma, in most cases, is caused by alteration of sonic Hedgehog signaling. So this pathway was actually discovered in patients with nevoid basal cell carcinoma syndrome that had underlying mutations in patch1 gene, that's inhibitor of sonic Hedgehog signaling. And then in up to 80% of now sporadic basal cell carcinomas, alterations in that pathway have already been found. And that pathway, therefore, is the candidate for targeted therapy. And there is an FDA-approved agent now, vismodegib, and there are several other agents as well now on the market, some without FDA approvals, that are already used for management of unresectable or locally advanced metastatic basal cell carcinoma or multiple cancers in patients with nevoid syndrome. This is a early study that has come out showing success of this management in patients with periocular basal cell carcinoma. And here we have a more recent study from Bita Ismaili in MD Anderson, which showed success of this as a neoadjuvant modality. So you have patients with advanced basal cell carcinoma where resection would have ended up in exenteration. They gave to this patient vismodegib as a neoadjuvant agent, resected residual basal cell carcinoma, and the patient is doing well now a year after this therapy. Obviously, like with anything, it's not panacea. There are significant side effects, and we don't know how long the patients have to be kept on it, because if you discontinue, it can recur. So there are some issues with this medication, but it does provide hope, especially to the ophthalmic oncologists. And it has been shown to be successful in management of this periocular nevoid basal cell carcinoma syndrome patients. So today, I will not go through all of the adnexal tumors. I will only touch upon the sebaceous carcinoma. And do you guys, before I move on into that topic, any questions on basal cell? Yes?
I do have a question. Does it make sense to try to decrease the tumor load in something like that last case that you showed prior to giving the medication?
So how would you decrease it? By excision?
Well, just by excision. You're not looking for clear margins.
Right. No, that's a good thought, but I think the traditional pattern for these advanced cases where excision can really result in significant defects, and then you would need to reconstruct, right? And you're reconstructing with tumor at the edge, right? So that's not going to work. So the typical pattern would be to first shrink the tumor in a neoadjuvant fashion, try to clear the margin as much as you can by neoadjuvant therapy, and then resect as little tumor as you can. Okay, so some of this is taken from our joint efforts by Rebecca. So Rebecca, my compliments to you for making my lecture easy and possible. So let's talk about sebaceous glands and sebaceous carcinoma. So we're all familiar with the sebaceous glands in periocular region, and they're quite numerous as compared to the sebaceous glands elsewhere. So, and that's why we as ophthalmologists end up managing these patients, and eye pathologists are used to seeing these tumors. So when you compare the upper eyelid to the lower eyelid, upper eyelid has more numerous sebaceous glands and longer sebaceous glands, so this larger mass accounts for predilection of sebaceous neoplasia to the upper lid location, as opposed to basal and squamous cell cancers, which are more typical in the lower lids. And just like with epidermal-based lesions, these are stratified into reactive phenomena or hyperplasia, truly neoplastic conditions, which are borderline or pre-malignant, and frankly malignant sebaceous gland carcinomas. So first about sebaceous gland hyperplasia, which in the past was called senile. Nobody likes the term senile, so we now got rid of that term. It's sebaceous hyperplasia. Presents as crops of yellowish nodules, typically head and neck, sometimes in other locations, with central keratin pore or umbilication. Kind of looks like molluscum or keratoacanthoma, but not quite. So that's the look of sebaceous hyperplasia. Completely benign, generally not associated with any syndromes. You can watch and wait as long as you know what you're dealing with, you're fine. That's what it looks like histologically. The key here is maturity and symmetry. So you see completely symmetrically arranged proliferation of sebaceous lobules around a central duct. And when you look closely, you can see that other than increase in size and increase in number, they look just like normal sebaceous glands, with germinative cells in the periphery maturing predictably into sebocytes, which ultimately shed into the duct in a holocrine secretion pattern. And mitotic figures are only limited to the germinative cells. Completely normal. Now, in contrast, we're going to move to neoplastic processes. And this is an example of well-differentiated sebaceous neoplasia. This is sebaceous adenoma, where we now see this yellowish lesion arising in meibomian gland, right next to the canaliculus. Closer look, again, well-circumscribed lesion, not infiltrative, with very mature sebaceous gland lobules, but can you appreciate how there are more blue cells? And there is more haphazard organization of the lobules? And there is more exuberant holocrine secretion type material that we call here chlamydia And mitotic figures are no longer limited to basal cells. So this is an example of sebaceous adenoma. And a similar lesion here, well circumscribed, with grossly very mature-looking sebaceous lobules with central lipid, with exquisite maturation towards the center of the lobule, with more immature cells and higher-grade mitotic figures. So adenoma and epithelioma are related lesions, and they are defined differently based on percentage of germinative cells. You don't have to be able to distinguish one from the other as long as you know about the importance of this association. So well-differentiated sebaceous neoplasia are associated with a cancer syndrome, which is typically inherited in autosomal dominant fashion, and that's why family counseling is incredibly important. And they have cancers in other organs like colon, bladder, stomach, and detection of these lesions in the lid can be incredibly important for both patients and their families. We all know that most of these patients with Muir-Torrey syndrome or Lynch syndrome will have mutations in one of the 4 mismatch repair genes. Some other genes are also now recognized. But with Muir-Torrey syndrome, more typically you will have loss of MSH2 or mutation in MSH2 gene that leads to loss of MSH2 protein. And that can be typically detected with immunohistochemical stains. So you can see in the top panel, there is no nuclear staining in the lesion for MSH2 and its partner MSH6, which is usually degraded because MSH2 protein is gone. And in contrast, there is retained nuclear staining in MLH1 and PMS2. So this is compatible with potentially Muir-Torrey associated lesion, and this young patient will need genetic counseling, potentially molecular genetic studies, and potentially oncologic workup. Okay? So this association with Muir-Torrey syndrome actually varies from study to study because definition of Muir-Torrey syndrome is not precise, and it's site-specific. So non-head and neck sebaceous adenomas and epitheliomas have really, really strong association with Muir-Torrey syndrome. In the head and neck, this association is relatively weak. And if you actually focus on the lids, can you see how it becomes very tenuous? But nonetheless, it is real. This patient has known Muir-Torrey syndrome. This patient has known Muir-Torrey syndrome. Okay, so we do need to be aware of that. Okay, so in the last few minutes, sebaceous gland carcinoma. Again, it's relatively uncommon depending on where you are, but we tend to see it because of predilection, because of numerous sebaceous glands in periocular region. So up to 70% of sebaceous carcinomas are seen by ophthalmologists, right? And the distribution varies. Here, it accounts for about 10% of all primary cancers, but in Asia, it can account for up to 60%. So it's much more common in those locales. And it's more common in women, more common in elderly, can follow irradiation, and as you know, can have genetic predisposition. Typically in the upper eyelid, and we've discussed the reasons for that, less frequently in the lower eyelid, and then even less frequently in the caruncle and conjunctiva. And you all know how it's a great masquerader, with the two most common presentations being atypical chalazion, where the tumor grows in a nodular fashion, or this chronic unilateral blepharoconjunctivitis. And misdiagnosis is quite common, so up to 50% of these are misdiagnosed clinically. So grossly, what do we expect to see? The key here is to see tumors centered in the meibomian gland, with potentially secondary extension onto the lid margin. And you can also see the same thing microscopically. Tumor is centered in meibomian gland with extension into the lid margin. That is a huge tip-off. And on higher magnification, compare the junction between normal meibomian glands and tumor, which is in situ here. Can you appreciate how the tumor recapitulates normal sebaceous gland architecture and normal sebaceous differentiation? But the neoplastic cells are much more aggressive looking, with chlamydia necrosis that recapitulates normal holocrine secretion. And on higher magnification, the cells typically here look moderately differentiated, where you can make out few lipid vacuoles in cytoplasm. Nucleoli are numerous. Mitotic activity is pretty brisk in most of these cases. Very characteristically, sebaceous carcinoma is going to involve the epithelium of conjunctiva, and that's why it looks like conjunctivitis. Here, it replaces conjunctival epithelium. And it can also involve the adjacent epidermis in a pagetoid fashion. And it can also shed into the lacrimal system. Here you see tumor involving lacrimal canaliculus, and you can see how this potentially can recur if it involves lacrimal drainage system. So this intraepithelial spread by sebaceous carcinoma is very well recognized, and it leads to the pattern of map biopsies. You have to be aware, though, that tumor on the surface of the epithelium can shed along with the epithelium. So we sometimes may see completely denuded biopsy. And that's a clue to us to look closer. And that's a clue to the ophthalmic surgeons to have a higher index of suspicion for intraepithelial sebaceous carcinoma. So these tumors generally don't give us a problem. Well-differentiated tumors, moderately differentiated tumors, where we can see sebaceous differentiation, are easy. These ones are really, really hard. And it's a huge histopathologic masquerader as well, especially in a small biopsy when you don't have the entire lesion. Again, with 50% only cases diagnosed accurately at outside institutions, in many cases because they were in small samples. And as you guys know, our special stains for lipid are limited by the need of unprocessed tissue, and they really have very low sensitivity and specificity. And there is no good stain for sebaceous carcinoma immunohistochemically. So we use panels. The panels have significant overlap, and we still greatly rely on morphology. Okay? So with our much better refined detection methods, both diagnostic, clinically and pathologically, this is uncommon. Okay, this is very uncommon now. So exenteration for sebaceous carcinoma is rare. Nodal metastasis is also relatively uncommon, although it can happen much more frequently than with squamous cell cancer. And here we can see tumor in lymphatics, and here we can see tumors in blood vessels. So distant metastasis can also happen, but less frequently now. So we're doing much better for our patients in the past decades. And this now brings the point of sentinel lymph node biopsy. So that's a controversial topic. In some centers, like MD Anderson, that's a pretty routine procedure for advanced sebaceous carcinomas. And there has been some work, again, from MD Anderson group showing the value of sentinel lymph node biopsy for these tumors from the standpoint of prognostication, okay? But there was a relatively recent study from Emory by Hans Chris Nicholas that really questioned the role of sentinel lymph node biopsy for ophthalmic cancer at present, just because of these potential difficulties. Okay, so here I think our protocol is that it is offered, but it is not greatly advocated. So the patient decides whether to have it or not. We don't endorse it. And then as to the Muir-Torrey syndrome, remember how sebaceous adenoma had some association with Muir-Torrey? Garden variety sebaceous gland carcinoma has almost no association with Muir-Torrey. So you guys as ophthalmologists, unless the tumor is well differentiated, unless the family history or personal history is suggestive of Muir-Torrey syndrome, it's probably okay to let it go. We don't yet have good guidelines for management of screening of patients of periocular sebaceous carcinoma, but the data suggests that typical sebaceous carcinoma in meibomian gland region can be left alone unless you have grounds for concern. Okay, so review questions in the last minute or two? Okay, let's go quickly. We'll do voting, okay? We're going to be very democratic here. Okay, so diagnosis first. What do you guys think? You can shout out. Blue or pink? Pink, keratinization, invasive. Okay, so what's your diagnosis? Squamous cell. Okay, so what's the typical location? Lower lid. Excellent. Moving right along. Diagnosis? Blue or pink? Blue. Palisading? Artifacts? Basal cell. Okay. Best answer there? Excellent. Moving right along. Blue. Yes? What's the likely diagnosis? Okay, how many think squamous? How many think basal? How many think sebaceous? Excellent, majority wins. Why sebaceous? Where is it centered? Tarsus, okay. Likely sebaceous. We need higher MAG. Are you guys right? Is it sebaceous? Yeah, you see now sebaceous differentiation. Good. So if this is sebaceous carcinoma, and it is, which of these are true? And I apologize, that's not proper format, but sometimes it's still useful. So which is the best answer there? Okay. Diagnosis?
Okay.
Excellent. Very nice. This is hard, but what would your guess be? Do you see parakeratosis? Do you see dysplasia? There is a suggestion of actinic elastosis. What's your diagnosis? Actinic keratosis. Good. So can you now try to put these together? Which is the best? A, B, C, D, or E? SK stands for seborrheic keratosis. Very nice. And almost last one. Okay, so you can all recognize this is the Muir-Torrey associated lesion, yes? Potentially. So what's the appropriate management? Excellent. B. Everyone good? Okay, and that's it. part 1 maybe next week or maybe at the end of the month, okay? All right. If you have any questions, I can stay a little bit. Okay.